Hello and welcome back to the Childbirth Education Series here at Holy Redeemer. My name's Sue and I'm one of the childbirth educators. Today's topic for discussion is pain and pain relief. And so many women have pain when they have labor. And some people will hear information about pain management and say, you know, before they get to the hospital, that's what I want, that's for me. Give me that. And I would say that's great. Plans are always wonderful, but keep in mind your plan should be flexible to include, number one, the unknown, or number two, the unexpected. So today we're going to talk about all the different types of pain relief options we have here at Holy Redeemer. Before we start that conversation, it's important that you know and understand that you have the right to know about any medication that we give you, the name of the medication, and why we're trying to give it to you. Additionally, you need to know to be able to make a really good decision about whether that's a good medication for you and your baby or not. Because we should be telling you also if there are side effects to using this medication and what could happen to you and to the baby if side effects are present. Additionally, we should also be telling you about, the expectation, what the medication should do for you and how it can help you or the baby. Regardless, the idea is we ask a lot of the same questions and we have a very strict protocol whenever we give you medication. So we always ask our patient for their name and date of birth to confirm who they are. And I know this seems repetitive, especially if it's the same nurse who's been caring for you the whole labor. Most of our nurses work about 12-hour shifts. So every time she comes in, you ask for medication or she needs to give you a medication, she's going to do the same thing. Please give me your name and date of birth. And then there's another key question she's going to ask. We ask it at the time of admission and we continue to ask it as well prior to any medication administration. And that is, do you have any allergies to medications? We would never want to make an error in giving you a medication that could cause you to have extreme side effects or the baby. So it's your responsibility to tell us if you know you have any allergies to medications. It's our responsibility to make sure we don't give you medications that contain the ingredients that you're allergic to as well. So let's start off about all the different options we have for pain management. So for some people, they say, you know what, I don't want anything too invasive. I just need a little help to get through my contractions. So we have an option that we can give through an IV. And so the two medications that we typically use are Nubain and Stadol. Nubain and Stadol. They're the two IV medications. Typically what I tell patients, if you're looking for your contractions to be a little less in the beginning, a little less at the end, and basically have good relaxation in between your contractions, almost going to sleep, one of those medications could be for you. I find that there's a bit of a timing concern about giving these medications. So we don't want to give these medications too late in your labor, because the idea is we give it to you through your IV. It goes through your bloodstream, and guess what? A few drops of that medication do cross over that placenta, umbilical cord, and go to the baby. So just like you'll be relaxed and sleepy. Guess who's going to be relaxed and sleepy if they get some of this medication? We typically see the baby in labor get a little less movement, and the heart rate is not quite as active when mom gets these medications. The duration of the medication usually lasts between 2 to 4 hours. Again, the idea of it affects your perception about the beginning and the end of your contraction, completely relaxes you in between. The peak, the hardest part of your contraction though, that's still the hardest part of your contraction. And even if you were somewhat asleep or just sort of kind of in a good place, you will be aware when you have that peak of the contraction. So for some women, I give the medication, it works very quickly, usually within a few contractions, which is wonderful. I find them, being awake and alert during the peak of the contraction, and then they go to sleep after that part. And so from mom's perspective, every time her eyes are open, she's having a contraction, the medication hasn't worked. What we know, myself and the support person, is that she's snoring in between her contractions, getting the rest that I said that she was going to get. Again, this doesn't take the pain completely away of contractions. It just changes your perception about what you're feeling for the beginning and the end of your contraction. Again, the downside is it goes through your bloodstream, so it affects you, but it also affects a little bit to the baby. We will not give this medication typically after you're 8 centimeters dilated, because the chances that you could deliver a baby quickly after that end point in your labor go up. So we want to decrease the risk of the baby being born with any of this medication on board. In the event that you deliver very quickly after getting one of these IV medications, we would call our neonatologist, who's a special pediatrician just for newborn babies, and they would come attend your delivery just to make sure that there were no complications after delivery from that medication to the baby. It's a good medication. You can get it several times in labor depending on how long your labor is lasting. And if what you're looking for is relaxation, the IV medications will help. However, if you're looking for no pain, then the IV medications are probably not the way that you want to go. So I want to talk, before I talk about the epidural, which is everybody has heard about, sometimes biggest mispronouncement as well as its name. But I want to talk about something called nitrous oxide. This is similar to the laughing gas that sometimes people get in the dentist's office. Again, changes your perception about your contractions. At this point in time, due to concerns about infection, we have not yet figured out how best to proceed with that option for pain management to make sure that people can be safe and use it. It's an inhalation medication, so meaning it goes through a mask over your face. And so we are not giving that at this moment in time. However, when we can figure out how to safely give it, that could be another option for you as well too. I'm going to move on to the epidural. The epidural is considered a generalized anesthetic. It's placed using a needle in the spine, about the midpoint of your back. The person who places this is going to be the anesthesiologist or a nurse anesthetist. So your nurse, while she can give the IV medications and she can give nitrous oxide, she cannot administer your epidural. She can, however, your nurse, prepare you for the epidural. And so the epidural does take a little preparation. You just can't ask for it and get it immediately. Versus the IV medication, the nurse can call your doctor, she can order it, and then the nurse can give it, it usually takes max of 5 to 10 minutes. The epidural takes a little bit of time, and here's why. So we need to prepare your body for the epidural itself. It does have side effects to it. So we want to make sure you have enough fluid in your body to counteract sometimes the medications that are given with the epidural. One of the side effects of the epidural is that it can lower your blood pressure. Less blood flow to the baby, less oxygen to the baby, it can decrease the baby's heart rate as well too. One way that we counteract that possible side effect is we give you extra fluid through your IV. So that does take time. We just can't push it in a minute. It does take about 15 to 20 minutes to get that extra additional fluid into your body. So we have to call the anesthesiologist, we have to call your physician, and we have to get the physician's approval, for you to receive the epidural. And typically, the nurse needs to let them know how the baby's heart is responding to labor, how you're responding to labor, that you have requested this and consented to the epidural. And so almost always your physician will say, yeah, no problem. And then we call the anesthesiologist. So we don't have the anesthesiologist on call just for labor and delivery. We share them with other areas of the hospital. During the day, there's usually somebody that can come readily available. In the evening and overnight, it may take a little bit longer. So the anesthesiologist or the nurse anesthetist will come, they'll talk to you, they'll explain the procedure to you, and they will get you to sign a consent. So if you can't sign the consent, they're not going to do the procedure. So just keep in mind that consent must be signed before the doctor does anything to you. And they're going to review some of the same things that I'm talking about with regards to the advantages and disadvantages. So most people choose the epidural because it really does take away almost all the pain you feel from labor. However, it sometimes substitutes something called pressure. And as the baby moves down the birth canal, sometimes what people will feel instead of pain when you have a contraction is the pressure of the baby's head on the pelvic bones, doing those special movements that they do to try to negotiate the birth canal. And so for some people, feeling pressure is no better than feeling pain. There's not much the doctor can do about the pressure. If you continue to have pain when you have an epidural, the doctor can give more medication. The anesthesiologist can give more medication. The whole procedure itself, if you can cooperate, which I've never had a woman who was unable to cooperate getting an epidural. If that's something that my patient wanted, as an experienced nurse, we can work with the anesthesiologist to get you through it in a minimal amount of time. Typically, the doctor prepares your back, they clean it, they drape it, they push on your back a little bit with some sterile gloves. They're going to use what's going to look like to your support person a really big needle. Well, in fact, there's not all of the needle doesn't go into the patient's back. What they're looking for by feel is the epidural space. The epidural space is where they're trying to get the needle to fit. Anesthesia's very experienced in doing this. They know exactly which bones to choose to go between. They know exactly how far in that they need to push the needle gently and slowly so they get to the space. They pull out their needle. They leave a small, tiny little catheter about the diameter of the tip of a pen in your back, in the epidural space, and they proceed to give you some test medication as well as medication that will bathe the epidural nerves and allow you to not feel pain when you have your contraction. Typically, people have to sit up for this procedure. That's most of our anesthesiologists' preferred position. So we talk about sitting up on the edge of the bed. We typically have to move your monitors around for the baby's heart rate because we are required to still try to hear the baby's heart rate, count contractions during the epidural process. So your nurse typically stands in front of you, and what the anesthesiologist says is, curl your back out like a boiled shrimp or an angry cat. So that this is the position they want you to get in, so that opens up the bones of your spine the maximum way that it can. So basically pushing your back out to the doctor, like an angry cat or a boiled shrimp, I've heard someone say. So the idea is that, they'll try to do the hardest part, which is finding the epidural space between contractions. Again, if you're having contractions every 1.5 to 2.5 minutes, that's going to be very challenging for anesthesia. This is where that breathing comes in. So even though you didn't want to go natural, the nurse is going to be breathing with you, and you're going to focus on her, and you're going to get through it. So maybe 1 or 2 contractions, the needle will still be in your back. After that, the doctor finds the place, they leave a catheter in place, and you can have a small amount of shimming or shifting. While the needle is in your back, the doctor is looking for epidural space. It's really essential that you stay quite still. Your support person can stay in the room. That's not a problem. The support person needs to be seated during the procedure. We've had some support people get dizzy when they see what's going on, and then we have 3 patients, the baby, the mom, and the support person that we have to take care of. So we always have our support people, either seated, or it would be a good time for them to go take a break, go for a walk, clear the head, make phone calls, get food, and then the time they come back, mom's happy, support person's happy, everybody kind of takes a minute and everybody gets a breath. So again, some of the side effects to the medication are it can lower your blood pressure, it can decrease the amount of blood flow to the baby, which is how oxygen gets to the baby, and it can lower the baby's heart rate as well too. If that would happen, we can increase fluids, and we can also have anesthesia come and give you a medication that can raise up your blood pressure again too. You kind of see where this is going. For everything that we do sometimes leads to something else, which sometimes leads to something else. It's one of those things that happens with regards to some of the very high level types of medications that we give, and epidural is probably one of the most critical ones that we give. It's the most sought after by patients, and it's the most intensive because it's so invasive. And big needles going into your back, and again, we have skilled people. Been here a long time, have done this many times. They're very quick at what they do. They're very accurate at what they do. And again, the catheter is left in your back. The small tiny tube is left in your back so that if the medication wears off, which it will do, that you can get more and get more again if you need to. Again, one of the disadvantages is at the time we need to have you push, you don't actually know when you're having a contraction. So we ask you to use the muscles of your body to push while your uterus is pushing as well too. And sometimes that doesn't work so well. It's kind of like trying to urinate if you can't feel yourself going. It's sort of a tough thing to do if you can't feel the muscles of your body to work. On other times, I've had patients who push really well and have no clue if they're doing it the right way or not, but we see the baby move down the birth canal, and that works out well. In that case, we may need to wait it out. We may need to let your uterus do a little bit more of the work. We may need to have the medication not be quite so all-encompassing. Need it to wear it off just a little bit so that you can feel just a little bit of when you're having that contraction, and feel your body moving as well too. So there's the obvious side effects as well too. So ideally the doctor is looking for the epidural space. Occasionally they go a little bit further and they hit the spinal canal. That's usually something that happens when a patient is really having a hard time staying still. Most often moms understand, nurses understand it's a critical time you need to stay still, and people do because they understand that the risk that's involved as well too. So again, that's a regional type of anesthetic. We expect that the body will be basically numbed from right underneath the breasts all the way to the tip of the toes. And I've had patients say, well, I don't really like that feeling. And I'm like, that's kind of the way you got the epidural. That's how your body absorbed the medication. So you should be able to wiggle your toes. You might be able to flop your legs around a little bit, but you're not going to be able to use your legs to walk. And that sometimes is disconcerting for patients too. But you can always breathe. It doesn't affect anything from your breast up. So it's the kind of medication that's just a regional anesthetic. Occasionally the doctors need to do a local anesthetic, which is basically numbing medication in a syringe that they will put into your perineum if they think you need an episiotomy. And again, that was that small cut that they might make at the end of your vagina just to open up your birth canal as much as possible to allow the baby to come through. Usually only done if it's a very tight fit for the baby, or if you need to have a vacuum extractor placed on the baby's head to help your delivery of your baby. We also have spinal anesthesia, and typically our doctors reserve that for patients who need to have cesarean birth. So when you have cesarean birth, there's one of two choices, spinal or general. So spinal is more encompassing. It goes up a little teeny bit higher, and it's a much more heavy, if you will, anesthetic that encompasses a little bit higher so that you don't feel any of the cuts the doctors are making during cesarean birth. General anesthesia, you're completely asleep. So for the spinal anesthesia, again, it's the same Gumby kind of a thing. You can't move anything. You could try to wiggle your toes, but it doesn't happen. You can't flop your legs around. It's a very heavy anesthetic. It's to give you full pain relief during cesarean birth. So we don't use spinal for labor patients. It's only used for cesarean birth patients. The only time we tend to use general is if there's no way the doctor can perform a spinal, or this is a true emergency situation and we have to get mom under anesthesia to get the baby out in a very fast manner. So typically we move very quickly for cesarean births. We have another class on cesarean birth that's coming up, and I encourage you to view that as well too. I hope you found this information to be helpful, and I look forward to seeing you again on another class. Thank you.